Hello, this is my case study presentation for DH222. I'd like to introduce you to Raul, a 37-year-old Hispanic male who is married with children and speaks very little English. He came in on a Saturday in January to get a cleaning, but I suspect his motivation for coming into the clinic was pain in tooth number 3. Raul meets the criteria for this project with stage 2 periodontitis, 30 teeth, and a 3 sub deposit level. Based on the patient's inflammation, I believed his periodontal condition could be improved with non-surgical periodontal therapy. Before starting any patient treatment, it's important to understand the DH process of care because it's the system we use to determine disease status, select appropriate treatment, and measure outcomes. You'll find the 5 elements of the process of care used throughout this case study. The patient's medical history contained no infectious or systemic diseases or existing conditions. He said he hasn't been seen by a doctor for a long time, which may explain his scant medical history. I asked if he smokes and he said no. His blood pressure readings were high at every appointment but one, and the patient was advised to have a medical consultation. During the dental history interview, the patient said he brushes once a day with fluoride toothpaste, grinds his teeth at night, and drinks about 4 sodas a day. I recommended buying a boil and bite mouthguard to wear at night, and I explained how sugar contributes to tooth decay and recommended he cut down on the soda. Dr. Soriano did an exam on February 5th and recommended extraction of number 3 due to significant decay. The microscope evaluation was motivational for the patient after reading the handout in Spanish and seeing the bacteria from his mouth on the monitor. In the sample, we saw a lot of gliding and spinning rods and a few spirochetes, and the bacteria were moving fast, putting him at a D risk factor. During the periodontal assessments, his tissues were generalized, moderate, hyperemic, enlarged, and edematous. He had a lot of bleeding sites, so I classified that as generalized, severe, spontaneous. He has furcation involvement on several teeth, clinical attachment loss throughout, and generalized, moderate, marginal, and papillary inflammation. His deposit level was a 3-3. Here's the perio chart from his first appointment showing significant BOP on posterior teeth, furcation involvement on all molars, no recession or mobility, and probing depths at 4 and above on 85 sites. His new patient oral photos show hyperemia and inflammation of the gums and malposed teeth, especially on the mandibular incisors. Intraorally, there is some stain and discoloration on the linguals of his anterior teeth. Interestingly, there's not a lot of superdeposit on the anterior teeth, but a large amount on the posterior teeth. Here's the FMX I took on January 23rd. I know there are errors on these films, but no retakes were done because once I saw the PAs for the mandible, I knew a panoramic would be more beneficial than to expose him further in order to get a diagnostic full set of x-rays. Here's the pano I took after the FMX. There are errors on this image as well, but it clearly shows impacted third molars. Here's my interpretation of the radiographs. Generalized moderate horizontal bone loss, large caries on number 3, radiographic calculus on 8 teeth, and furcation involvement on mandibular first molars. I also listed the radiographic errors I made on the FMX and pano so that you can see that I am still evaluating my technique in order to make it better. When filling out the treatment plan form, I determined he was moderate for systemic and behavior risk because he hadn't been to a dentist a long time, moderate for caries risk, mainly due to the active caries lesion and frequent sugar exposure, and high for periodontal risk based on my findings during the perio exam. I used the Philips Care online risk assessment tool. This is the patient interview for the dental caries risk assessment and the clinical guidelines for high caries risk. I didn't find the patient handout useful on any of the risk assessments because the recommendations seemed generic and felt more like advertising than patient information. Here's the completed patient interview for the periodontal diseases risk assessment. This tool has determined he has a high periodontal risk, and the middle picture shows clinical guidelines for this risk category. Here's the completed patient interview for the oral pathology risk assessment. My patient fell into the low risk category mainly because he doesn't smoke and has not previously had cancer. The goals, interventions, and expected outcomes on the treatment planning form are pretty generic for most of my patients, but the information is still relevant because the goal is to reduce probing depths and BOP and arrest the disease. At initial appointments, I like to start home care instructions with the basics, brush and floss. For this patient, the most appropriate dental hygiene intervention was perio scaling by quadrant with local anesthesia and fluoride varnish. With information from all the assessments, I determined his dental hygiene diagnosis to be stage 2, grade A periodontal disease. The initial treatment plan called for 4 appointments and was presented to the patient by a translator, and the NSPT consent form was provided in Spanish. We followed PARQ and explained the alternatives and risks and allowed the patient to get his questions answered. Informed consent was obtained. This is the initial treatment plan that's saved in the patient's chart smart docs. The patient's last name and signature has been removed for privacy. The treatment plan changed almost immediately. I was supposed to start perio scaling on the second appointment, but that appointment started at 3 p.m. because that was the only time the patient was available. Dr. Soriano did his comprehensive oral eval and I did the microscope, so there just wasn't enough time to start scaling. The third appointment was crazy. He came in for a CRC on a Saturday and my first attempt didn't qualify. When I calculus charted the patient, the upper right had 12 surfaces and the lower right had 14 surfaces. So I thought he could be my test patient for both CRCs in winter term. And since the first CRC only needed 12 surfaces, I just decided to do the upper right first. When I removed the deposit from number 3, the caries lesion was bigger than we thought, and the tooth didn't qualify because there just wasn't enough tooth structure. Patient was super awesome though and agreed to come back for the afternoon so I could attempt the CRC on his lower right. I passed that competency and I did gingival curettage on number 27 through 30 to remove the diseased pocket lining and placed a Reston into the 7mm pocket on number 31 mesial. The treatment plan had to be modified to include perio scaling of upper left and lower left at the 4th appointment. Here's a snapshot of the first appointment on Saturday, January 23rd. I created his medical history in EagleSoft and took vitals. His BP was high, so I retook it after 5 minutes and advised the patient to see a doctor. I did the FMX, Pano, perio exam, and caries risk assessment. The second appointment was on February 5th, and the patient had the comprehensive oral eval by Dr. Soriano. Doctor recommended extraction of number 3, and I did the microscope assessment, which I found to be interesting and motivating to my patient. The third appointment was the one where I attempted my CRC. When I ultrasonicked and hand scaled the upper right, I used Septicane for the PSA and AMSA. And when I perio scaled the lower right, I used lidocaine for the Gaugates, IA, and SP on number 25. When I review the notes for this project, I have recorded using a 1/4 cartridge of Septicane and 4 cartridges of lidocaine. That doesn't seem right to me. So I suspect this is an error that I made while making my chart notes. During this appointment, Jeanette was able to translate information about gingival curettage and Arrestin to the patient to get informed consent. The 4th appointment was to finish NSPT, and I ultrasonics and hand scaled the upper left and lower left, performed gingival curettage on number 22 to 25, and placed Arrestin into the 5mm mesiobuccal pocket of number 16. Local anesthesia for the upper left was 2 cartridges of Septicane for the PSA, MSA, ASA, GP, and NP, all given by Kaylin. For the lower left, 2 cartridges of lidocaine was used for the Gaugates, IA, long buccal, and SP on number 24. The client's brushing has increased to twice daily, which I thought was promising. And when evaluating previously debrided areas, there was supra biofilm on anteriors and moderate inflammation on number 25. After treatment, Kaylin translated arrest and post-op instructions into Spanish for the patient. And we also gave him a brochure about periodontal disease in Spanish. The plan for continuing care is the extraction of number 3 and perio maintenance in 3 months. The patient's perio re-eval appointment, or appointment 5, was just a few days ago. His BP was still high, and I advised him again to see a doctor about possible hypertension. The patient reported brushing 3 times a day, but only flossing 2 to 3 times a week, and he also still drinks about 4 sodas a day. I did a plaque assessment on him, knowing that was a requirement of the case study project that I hadn't done previously. I also did a microscope assessment, which was much better than the pre-treatment assessment. We didn't see any spirochetes. There were less rods that were slow, and so his risk level dropped to a B. During the perio exam, the tissues were generalized slight, hyperemic, and large and edematous, and BOP was localized slight, and furcation involvement could only be detected on 5 molars. His perio diagnosis stayed at stage 2, but I changed the grade to B. In winter term, I graded patients an A if they don't have diabetes and they don't smoke. During spring term, I started integrating the % bone loss per age into the grading criteria, and that's why I changed his grade to a B. His deposit levels at the 5th appointment were 2-2. Here is his perio chart at his re-eval. It shows a lot less bleeding sites, less furcations, and better proton depths. I took these photos at his re-eval, hoping to get a better image for occlusion, but there was a blurry spot on the camera lens that interferes. The intraoral photos from his re-eval look better than his initial appointment because there's no stain and minimal inflammation. Here are the pictures of the patient's teeth with disclosing solution. The highest areas of plaque accumulation were the facials of the mandibular incisors and interproximals of the molars. It makes sense to me because the malposed teeth are on the mandibular incisors, making home care more difficult. And since the patient hasn't been flossing regularly, it makes sense that there's high plaque interproximals of the molars. Now that he has had regular dental care for the past 3 months, his systemic and behavior risk factors and periodontal risk factors decreased. His carie risk factor remained at moderate, mainly because of the 4 sodas he drinks a day. At this appointment, I ultrasonic, hand scaled, and polished his entire dentition. When I was done, Kaylin performed gingival curettage on number 29 through 31 and number 18 through 20 with no anesthesia. I thought the plan for continuing care could be perio maintenance in 6 months instead of 3 months because his oral condition had greatly improved and he's been compliant with home care recommendations. This is the treatment plan from the perio re-eval. Initially, it didn't include gingival curettage or a Reston placement. These procedures were performed at appointments 3, 4, and 5. And at all 3 of those appointments, I forgot to complete a treatment plan change form and have the patient sign it, but he did give verbal consent in all cases. Comparing pre-treatment assessments with post-treatment assessments was very encouraging. Probing depths, BOP, and inflammation all went down, which is in line with expected outcomes from the initial treatment plan. There was a ledge of calculus of gingivally on a few mandibular posterior linguals, and the only inflammation was on the mandibular anteriors, and I suspect there was burnished calculus there that is still a trap for bacteria. This is also the area where his malposed teeth are. This is a comparison of pre and post-treatment perio exams. The numbers in green indicate which probing depths have improved. There's a summary at the bottom that I found very helpful when analyzing the data. These are the oral hygiene instructions given to the client at each appointment. At the first appointment, I demonstrated sulcular brushing on the typodont. The second appointment, I demonstrated sulcular brushing on the patient. Because the third appointment was so long, I felt no modifications to home care should be made at this time. I demonstrated C-shaped flossing at the 4th appointment and provided different sized interproximal brushes for the patient to try. At the perio re-eval, I wanted to put it all together and reinforce the recommendations of sulcular brushing for 2 minutes twice daily, using a toothpaste with fluoride, and cleaning interproximally with floss and or interproximal brushes. The motivation strategies, I think for me, was the most difficult part of this case study because of language barrier. Normally I chat throughout an appointment and get to know a patient, which helps me figure out what motivates them. Raul's English was about as good as my Spanish, so I had a hard time understanding what his motivations are. I didn't even know he had kids until I saw their picture on his phone during the PERIO REEVAL. In general, though, I believe the patient is at the evaluating level of Bloom's taxonomy in regards to his oral health and at the esteem level of Maslow's hierarchy of needs. I know that he's an illegal immigrant, so I would assume there's always some anxiety about being deported, so his level may fluctuate due to unmet safety needs. Besides PERIO scaling, there were a few additional treatments to optimize, there were a few additional procedures to optimize treatment, including placing an antimicrobial in deep pockets and performing curettage to remove diseased tissue. I didn't think it was necessary to polish at any of the PERIO scaling appointments, but I did selectively polish at the PERIO REEVAL. Fluoride varnish was applied after PERIO scaling was completed and at the REEVAL. The dentist had recommended an extraction of number 3, and the patient had that done at LCC Dental Clinic on March 20th by Dr. Baker. The high blood pressure readings at nearly every appointment was concerning to me, and at every appointment, I recommended that he visit a doctor to get his blood pressure checked. The prognosis for the patient is fair for a few reasons. He's still not flossing and is still drinking 4 sodas a day, probably because of where he is on Maslow's hierarchy of needs. I think he knows that his behaviors have detrimental effects on his health, but is not ready to commit to change. He may also have some difficulty in financing dental treatment, finding childcare, and having reliable transportation. I think the NSPT was successful in arresting the progression of periodontal disease, but I think he will suffer from further tooth decay. I also believe he has undiagnosed hypertension, but will probably not seek medical treatment. I really enjoyed working with this patient to stabilize his periodontal condition, and I'm proud of the results. I had a lot of learning moments with this project, especially with my chart notes. My tissue statements didn't seem consistent, and I think there may be an error on the amount of local anesthetic during appointment 3. Overall, though, this has been a great experience, and I'm grateful to all of the faculty and staff that have helped me get to this point in my education. Thank you.